Hi, my name is N Van Regenmortel. I'm an internist and intensivist in Belgium, Antwerp. And I'm going to give you a quick introduction to this session on maintenance fluids. So my topic is main topics in maintenance fluids. These are my disclosures. I got some grants from Baxter to perform a study on maintenance solutions 1 or 2 years ago. Just a quick reminder that there are three reasons for fluid therapy. We have, of course, resuscitation, which means that we are going to try with these fluids to correct hypovolemia or hypovolemic shock in patients. Then we have maintenance fluids. This is the topic we are going to talk about in this session. Maintenance fluids are there to cover patients' daily needs for water and electrolytes. And some guidelines say that they also serve in avoiding starvation ketosis, which is a little bit under discussion, but their main goal is give patients that cannot eat or drink water until they can eat or drink again, or until there is a certain amount of nutrition or parenteral nutrition prescribed. Then finally, we have the replacement solutions. These are for a variety of purposes, mainly to cover ongoing fluid losses or ongoing electrolyte losses. So this is for patients experiencing fever, diarrhea, they have fluid or drain losses, hypokalemia, hyponatremia, hypernatremia. So this is kind of a very big number of indications that replacement fluids are there for. But now talking about maintenance fluids to cover the daily needs. These are the main constituents of maintenance fluids. Some of them are under discussion, of course. The first one is water. The second one is sodium or sodium chloride or salt. And then we have some potassium. And sometimes in maintenance solutions, there is phosphate, magnesium, and even some calories to avoid this starvation ketosis. So these are the main questions. The first one is a combination of water and sodium called tonicity. And should maintenance fluids be isotonic or hypotonic? It's a really big debate that started with the pediatricians calling for isotonic maintenance fluids, but there's still something to say about that. And this is the main topic here, and I will touch upon it shortly. The second question is potassium. How much do we give? What does it do? Where does it go? And especially important it is that potassium is something that goes in the intracellular volume, which is, of course, a totally different place than sodium and chloride in water. Thirdly, we have phosphate, calories, and magnesium, and I will discuss them in a few minutes. But now turn to this most important question in maintenance solutions. Should maintenance solutions be isotonic or hypotonic? And it's best to have a look in to what really happens in health, not in patients, but in just human beings. And we all know these food triangles in Flanders, we put them upside down. But the main thing is that we are advised to drink mainly water, 2 to 2.5 liters a day, and to cut down a little bit on sodium. And if we look at the recommendations, we see that we are advised to have a maximum intake of sodium of 2.3 grams. I'm not talking about salt, I'm talking about sodium here. 2.3 grams of sodium with 2 to 2.5 liters of water, which means that our mean sodium concentration of intake on a typical day is 40 to 50 millimoles per liter of sodium of water, sodium per liter of water. In health, in diabetes and in hypertension, the guidelines are even more decisive, cutting down sodium to 1.5 grams per day. And this is typically reflected in an average parenteral nutrition, enteral nutrition or parenteral nutrition, where it is advised, where typically these solutions contain, again, 40 to 50 millimoles per liter of solution. And the funny thing is that from the moment we enter the hospitals and our nurses are administering some fluids prescribed by the doctors, then we see that now, especially when we are choosing for isotonic fluids, we give lots and lots of sodium, more than we are used to in our out of hospital life. For example, 1 liter of sodium chloride 0.9% or normal saline contains 3.5 grams per liter of sodium, or 154 millimoles per liter. And even when using these typical balanced solutions like Ringer's lactate or Ringer's acetate or plasmalite, there is still a tremendous amount of sodium in 1 liter of these fluids. And again, we need more than 1 liter of water per day. We need about 2 to 2.5. So just by doing this with these solutions would give enormous amounts of sodium. And the question, of course, is this important? What should we do now? Should we prefer isotonic maintenance solutions with a risk of sodium overload? Or should we prefer hypotonic maintenance solutions with the risk of hyponatremia, which is a well-known problem, especially in pediatrics? So there is the first question again, is this extra sodium a problem for patients? So kidneys are beautiful organs and they should be able to deal with large amounts of electrolytes that are being administered. But no, it is not completely safe or completely normal to give large amounts of sodium, in that the kidney takes a few days, 5 to 6 days, to recalibrate output versus input. So even an organ that takes so much blood and can filter so much plasma cannot deal, obviously, within the range of 4, or it needs 4 to 5 days to just comply with or just deal with this increase in sodium. And this is experiments from the 50s, when we increase sodium, low sodium diet from 0.5 grams of sodium per day to 2.2 grams per day. We need 4 or 5 days to match intake with output, and in the meantime we get fluid gain and a fluid balance that is positive, and a weight gain of around 1 kilogram. So the kidney is clearly not able to deal with this swiftly, as opposed to, for example, potassium, which can be dealt with within minutes or hours. The same thing was proven in modern experiments. This is in cosmonauts by Titze et al., who showed that when we are augmenting diets of astronauts over many, many days, we see again weight gain. You see clearly that at a certain time we reach a certain plateau here, and this is that at this time sodium will be stored non-osmotically. I'm not going to elaborate on that. This is for another talk of my colleague Old Engbrink in the next session, but I'm going to talk about this weight gain, this fluid gain by sodium increase. A good question is, why is the kidney why is it so difficult for the kidney to get rid of this sodium? You should expect at this amount of filtration that sodium should be perfectly dealt with within minutes or hours, and it is not the case. Why is it not the case? It is because we don't have in our tubular system one typical place where we can actively secrete sodium. It's nowhere in the glomerulus or nowhere in the tubules that we can do this action. And why is this? This is because we are, through evolution, we are used to deal with dehydration, with a shortage of water, and we never, throughout the millions of years of evolution, we were never obliged to deal with large amounts of sodium. This is a modern problem. This is a problem from the last few decades. We can call it the McDonald's era, where now we have to deal with large amounts of sodium. This was never a problem in true mammalian evolution. So sodium in our body is there to conserve water or to protect us from dehydration, and we are not used to deal with large amounts of sodium. So we put that to the test a few years ago, 1 or 2 years ago. It was published last year. And what we did was we tried to measure the effect size of what is a typical maintenance fluid regime when we applied isotonically or when we applied hypotonically. So we took a few patients, 72 of them, and we gave them a typical amount of maintenance fluids, 72 ml per kilo per day, and one fluid was isotonic, was normal saline, 154 millimoles per liter, and the other was 54 millimoles per liter. It's a commercial solution called Glucion. Just to measure what is the impact on fluid balance when we only change in this typical group of major surgery, it was thoracic surgery, what will happen on fluid balance. And what we saw is that we gave enormous amounts of sodium even in this hypertonic group, just because these patients need some resuscitation fluids. And we see that after 3 days, 4.6 grams per day went in the hypertonic group, 8.4 grams per day went in the isotonic group. And on a fluid balance, we saw that there was a difference of 1.3 liters, that the fluid balance was more positive in this isotonic group. We all know that these days, we know that a derailed cumulative fluid balance is a bad thing. We know that it's associated with mortality and morbidity. We know it in pediatric patients. We know it in adult patients, in mechanically ventilated patients, in surgical patients. We know that a derailed cumulative fluid balance is not a good thing. So maybe this change from normal diets towards a high sodium diet is a problem. Of course, the discussion remains whether hyponatremia is an issue. Then we have the back to the main topics in maintenance fluids is the potassium. Potassium is a very important electrolyte, although it is in very low concentrations in plasma. It is in very large concentrations there in the body because it's mainly intracellularly present, especially in critically ill patients, but also in hospitalized patients. It is more or less low because there is increased entry into cells due to stress, due to alkalosis. We lose more potassium gastrointestinally and urinary, and there is of course a decreased intake. We have to acknowledge that the normal intake of potassium is 1 millimole per kilogram per day, and we have to acknowledge that hypokalemia as well as hyperkalemia is quite frequent in critical care and has prognostic implications, not only in critical care, but also in the hospital. I'm not going to elaborate on this model, but we all know that potassium is a mainly intracellular ion or electrolyte. And it's always a little bit strange that we don't seem to regulate intracellular volume that much. It increases and decreases with the amount of fluids we give. Now, there's a very interesting theory that my colleagues Nesten and Zeilemakar-Hoestra in the next session will discuss, is that actually potassium contributes to a very close regulation of intracellular volume. I'm not going to elaborate further because my time is quite short here, but I'm sure they will deal with this adequately in the next few talks. Then we have a few minor things that we can discuss in maintenance solutions. One is, do we need phosphate? Is it a problem? How much of it do we need? Do we need it in maintenance solutions? Magnesium is the same thing. Do we need it? How much do we give? And finally, do we need some calories? Do we add some glucose or dextrose in maintenance solutions? The main reason is to avoid starvation ketosis. On the other hand, what is very typical is that we cannot, and this is important, we cannot create hypotonic solutions that are isoosmolar without glucose or dextrose. So the main reason that we add glucose or dextrose to these solutions is not only to prevent starvation ketosis, but also to be able to make these solutions at least a little bit isoosmolar to avoid hemolysis, of course. You cannot give normal water with just 40 millimoles of sodium per day, because this will introduce hemolysis. So I'm going to stop here. This was it all for an introduction. The main question is, do we need maintenance fluids at all? And we will discuss this at the end of this session in the live debate. And I thank you for your attention, and we see each other